you all so much in advance for attending my presentation and participating in the Fall 2022 Colloquium. I am Chanel Underwood, and I am a Master's of Social Work student at the Diana R. Garland School of Social Work. My presentation will be covering integrating spirituality in the treatment of schizophrenia. So, a little bit about me. I am from Maryland. However, I'm currently living in Fayetteville, North Carolina, which is also the home of one of the largest military bases, which is Fort Bragg, soon to be renamed, I think, Fort Liberty. My education includes a master's in public administration, a bachelor's in social work, a bachelor's in criminal justice. My volunteer work in the community includes being a guardian ad litem for the Cumberland County Court System and being the intake coordinator for the We Rise Veterans Foundation, which caters to female veterans of all branches. And my military service includes 21 years of service. And during that time, I predominantly worked as a pharmacy technician for about 10 years. And then I transitioned into being a paralegal for about 10 years. I retired January of 2018, January 1st. And then I transitioned into being a paralegal for a little bit of time for the North Carolina Community College of Systems in Raleigh, North Carolina. And then I became a legal assistant in the legal office at Forces Command until about February of this year, which I left that position to pursue my master's of social work degree full time. During my internship, I was selected to be an intern at Cape Fear Valley Health Hospital, which is the largest hospital in our region, and it has 8 other hospitals in this system. During that time, I had rotations in the emergency department psychiatric unit, at the Dorothea Dix Care Unit for adolescents, at the adult inpatient clinic, and also in the outpatient clinic for community health. So a little bit about what we're going to be covering in this presentation. You can see here in the agenda will be an overview, a cultural perspective. We're just going to touch on that a little bit. Some of the common interventions that are used with schizophrenia, and then we're going to talk about integrated spirituality. And for those of you who are participating in the live presentation, there will be an opportunity for closing remarks and questions. For those of you who will be viewing it on YouTube, feel free to place your questions or comments in the comment section. So some of the objectives that will be covered that I hope that you will come away with a better understanding of is the symptomology, the treatments that are used to manage schizophrenia, and understanding how you can integrate spirituality into the treatment of schizophrenia or any other disorder that you may be treating. So getting started. So first we're going to talk about the criteria that is or that needs to be met in order for an individual to have a diagnosis of schizophrenia. And this is in accordance with the DSM-5. So criteria A has a list of symptoms that a client needs to be experiencing for a period of about 30 days. And they need to have 2 or more symptoms listed in 1 through 5, right? However, one of those symptoms have to be delusions, hallucinations, or disorganized speech. So what you see here, in addition to that, is grossly disorganized, being grossly disorganized, or catatonic behavior, or other negative symptoms. So it's very important that the individuals that you're screening for schizophrenia have 2 or more of those symptoms, with one of them coming through from 1 through 3, and that they've had it for a period of 30 days. However, it is possible for them to have it, these symptoms persist for um, a shorter period of time due to medical intervention. So let's say they didn't make it the full 30 days because they were brought into the ER because some of their delusions and hallucinations was leading to um, behaviors that could be harming to them or others. Then then they wouldn't need to meet the full 30 days, obviously, because they will likely be treated and those symptoms will subside. Criteria B talks about major function areas, and this is a deviation from an individual's normal routines or their normal level of operation. So, in an adolescent, what that may look like, it may look like unable to maintain academic standing or to keep up academically, difficulties maintaining interpersonal relationships with their friends, declining relationships, inability to keep up with chores, with personal hygiene, or just a general upkeep. And this is a deviation from their normal behavior. So maybe if they don't keep their room clean, it will be worse than normal. Or if they're having difficulties in their friendship, it will turn from just challenges to isolation. Or if they're struggling in school, then they would be struggling even more. So this is a deviation from their normal level of abilities or their capacity. In adults, this may look like difficulties keeping up with work. The same thing, interpersonal relationship difficulties with maintaining home responsibilities, just falling behind, unable to um, maintain personal hygiene and interpersonal relationships. That's what that may look like. Criteria C talks about the time frame, which is generally 6 months. So you got 6 months of persistent behaviors, and then 30 days of uninterrupted symptoms such as delusions, hallucinations, or disorganized speech, or just grossly disorganized catatonic behavior or other negative symptoms that persisted for 30 days. However, this tends to drag out for a period of 6 months. So you want to observe it for 6 months just to ensure that what you're seeing here is something that is not returning to normal, or they're not returning to their normal behaviors. This is like ongoing for a period of 6 months. D talks about schizoaffective and mood disorders. So what you want to do is you want to rule out any other psychological explanations for the symptoms that they're experiencing criteria A, such as major depressive disorder, or manic episodes, or bipolar disorder with psychotic features, or schizoaffective disorder, depressive. Now, I do want you to keep in mind that it is very possible that schizophrenics have depression, or that they have bipolar disorder, or they have other mental health diagnosis that is co-occurring with schizophrenia. However, the symptoms that they're experiencing schizophrenia needs to be the one that is most predominant that they're experiencing. And then letter E talks about screening for other physiological explanations for the symptoms that the individual is exhibiting. For example, you want to screen to see if maybe this is due to some sort of response to a prescribed medication such as Ambien, or if they are experiencing side effects of illicit drug that is a hallucinogen, you want to screen for that. So doing a tox screen or a drug test is very important to see if they're clean for that. Or you can just ask them verbally to see if they have a history or they have recently used any type of substances that they don't normally use. Um, and then, of course, you want to screen for possible brain injuries or any kind of brain trauma that can explain some of the auditory or visual hallucinations that they're experiencing or any of the hallucinations. And then F talks about screening for a history of any kind of autism or anything on the spectrum. And then some of the specifiers that we do commonly use with schizophrenia are the severity, whether or not catatonia is present, and what phase of the disease we're in. So moving on. So some of the general facts that I pulled out of the DSM-5 are the onset. So I think it's very important that we know the age range in which we should be looking at for the onset of this disease. So it is very common for males to be diagnosed in their early 20s or start seeing some of the symptoms of schizophrenia. And for females, it's their late 20s. There is a late onset, however, that is commonly seen in women who are over the age of 40 who are married. There are, this disease can be diagnosed in children, but of course, it's very difficult to diagnose children with schizophrenia because they typically already have a very active imagination. And most children, or a lot of children, will have an imaginary friend, or they'll refer to something that doesn't really exist. It's just something that they made up in their mind. And it takes a little bit extra work to discern whether or not the child is experiencing true auditory and visual hallucination, or if this is just a byproduct of their imagination. So you have to be very careful with that. Another thing is that um, okay, so the onset range is actually from the late teens to mid 30s. So that's when most people are commonly diagnosed. And then the psychotic features decrease with age. However, I can say that within my internship, that I did not see that. I saw individuals who had been living with schizophrenia for quite some time. They were in their 40s and 60s, and they were still having challenges in maintaining their disorder and remaining in compliance with their treatment plan. And so they would have relapses to where they were not complying with their medication or psychotherapy, which led to a psychotic episode, which led to their hospitalization. So I have seen during my internship many clients and patients who have very, very significant symptoms into their late 40s, 50s, and 60s. So some of the statistics that we have on this disease, according to the World Health Organization, about 0.32% of individuals worldwide have a diagnosis of schizophrenia. Within the US population, the range is between 0.25% and 0.64%. And this is at a cost of about $150 billion a year. And this includes lost wages, medical treatments, emergency responses, lost productivity, those sort of things that can account for the $150 billion price tag. And then lastly is individuals with schizophrenia are 2 to 3 times more likely to die earlier than the general population. That's due to a multitude of factors. It could be either suicide or accidental death. So moving along to cultural perspective. So I've added this in to my presentation a little bit later in my research is because as I was doing my research and as I was continuing in many of my classes and attending many conferences, the cultural perspective came up routinely. And that is the inequities in diagnosing and the prevalence of mental disorders in those who are of African descent or just minorities in general. And so it calls for us maybe to take a little bit of a time out and take a real look at how we're diagnosing individuals and see if maybe there is a tendency to diagnose minorities and individuals of African descent with mental health disorders. And culture really does provide some context to the problem that we're experiencing in our mental health, our physical health, and just in society in general. So I think it is really important to view mental health issues through a cultural lens, or to at least take that into perspective when we're doing our diagnosis and when we're meeting with our clients, and do a good history on individuals' culture and how it impacts their care. So over the past years, there has really been an increased awareness of the rate at which African Americans, minorities, people of color are diagnosed with schizophrenia. So that is something that I think would be good to have on your radar. And so when we're looking at the data shows that, as you can see here on the screen, the African Americans or individuals of African descent are 2.4 times more likely to be diagnosed with schizophrenia than their Caucasian counterparts. And this is at a rate of 3 to 4 times higher. So there could be a lot of things that are attributed to it that I have some listed here. In the DSM-5, it does kind of allude to some vulnerabilities that exist within a certain minority group, but it does not explicitly say African Americans or individuals of African descent or minorities. However, African Americans are more likely to be diagnosed with schizophrenia. There's a lot of literature that states that African Americans, that the disease is more prevalent within that racial group. So this is a pattern that could be a result of various complex factors, such as misinterpreting the potential symptoms, differences in severity and types of symptomology, socioeconomic differences, cultural stereotypes, impaired provider patient communication, provider cultural competence. So but sometimes it's just simply in the way in which people are articulating their experiences or their diagnosis or maybe some of their symptoms is not consistent with the provider's understanding of the problem, which could lead to a misdiagnosis, just a barrier in communication or understanding, or a lack of common definition of certain experiences that minorities are trying to describe, or misinterpretation of some of the behaviors that are seen in other cultures. Sometimes an individual who is fearful, um, the way their behaviors or their responses to certain things can be perceived as aggression, or something that's very normal within a particular culture can be perceived as abnormal in another. So the increased rates of diagnosis really does necessitate an examination of our own perceptions of the mental health system and available treatments by minority groups, just as a step forward to eliminate some of the inequalities that we see in diagnosis. So that's just something for you to think about. Which brings us to our first point of discussion, which you can discuss, which will be discussed in the live session. But of course, here, this point of discussion can simply be something that you bring up in the chat box. Please feel free to do so. So what it states here is research states that schizophrenia is more prevalent in those of African descent. Do you think these scientific assertions influence how clinicians diagnose patients? So basically, what we're asking here is, do you think that the data is saying that schizophrenia is more prevalent in African Americans? Do you think that is influencing clinicians when they're doing their diagnosing? When perhaps it could be something else? Because I will say that it's really a detriment to the patient or client if you start treating them for schizophrenia and that's not really what they have. If they have something else such as schizoaffective disorder or bipolar disorder with psychotic features, so those treatments look a little bit different, right? Or if they're just experiencing catatonia, right? So if you're just experiencing catatonia and you don't have some of the other symptoms, or if you come in and maybe you have catatonia and you're just so angry because because you come out of your catatonia and you're now in this hospital environment, you're disoriented, you don't know what's going on, you have like maybe a distrust for the system, and you just see all these people around you, so you start flipping out, and they interpret it as maybe disorganized speech or disorganized behavior. Just like that, you have met three of the criteria for schizophrenia, right? And so now you're dangerously close. And then to being diagnosed with this disease, if you're also African American. So, like, the clinician is like, okay, I see this guy here. He's 18 years old. He was catatonic for a period of 3 days. He was unresponsive. Now he's awake. He's flipping out. Nobody can understand what he's saying. So we've got disorganized speech and we're unable to control him. So we got disorganized behavior. Um, yeah, I think he has schizophrenia, right? But you can't really make that diagnosis in a hospital environment or an emergency department because you need 6 months worth of history to be sure. However, how likely do you think it is that emergency department doctors are putting that diagnosis on that patient's chart? And so now, once that diagnosis has been placed on that patient's chart, they will be handled accordingly, right? So what really ended up happening is that the client didn't have right disorganized speech or disorganized behaviors. He was just simply angry. He was scared, which caused fear, which caused confusion, which caused him to slur his speech because his emotions and his behavior was moving a lot faster than his mouth could, right? I'm sure a lot of us experience that. And so you can easily see how him just being an 18-year-old African American, like, I think that's it. And then many of us, if you ask, do you ever see shadows? Do you ever see anything off to your side or in your peripheral? Or or do you have beliefs that other people tell you are unusual? Most of us can say yes, right? So let's say that you happen to be of African descent and you're Muslim, right? And you are in a facility that's predominantly Christian, or you're at a Christian hospital, Catholic hospital, and you say that you believe, in Allah and you believe this and I'm going to get this and that. They're like, okay, this guy's delusional. That's not going to happen. That's not what happens when you die. So now you inadvertently met criteria for delusion. Now, with visual hallucinations, you can say, yeah, how many of us think that we see something out of our peripheral or a shadow that's really not there? It's nothing, right? I'm sure a lot of us have had that happen. So, with me saying that, do you see how easily how things can kind of cascade into something it shouldn't be, simply because there is a cultural context is being missed, right? So that's just something to think about. moving along to some of the interventions. So I will caveat this. I am not a physician, I'm not a psychiatrist, and I'm not a psychologist. So we'll keep that in mind. That's my disclaimer for this slide. And of course, I'm not endorsing any drug. I'm not endorsing that anyone be on any kind of drugs. However, I will say antipsychotics have been proven to be 70% effective. Yeah, approximately 70% of patients is is have seen a substantial improvement in their symptoms, which I really think is amazing that scientists have figured out what it is in the brain and how to treat that medically to turn off the voices and to turn off the hallucination. It is really amazing to see a client before they are medicated and after. It's night and day, night and days. Two very different people. Very amazing. Now, I will say, as a social worker, you will not be able to really do a good assessment on someone who is actively having hallucinations and delusions. It's very difficult to get them to be in the present moment a lot of times. But once you get the medication on board, you can have a discussion with them and they can tell you about what they're hearing and seeing. It does not change the fact that they believe a certain thing wholeheartedly. Like if they believe that there are Wi-Fi chips in their arm, or if they believe that um, the end is coming, or they believe that their neighbors are listening to their conversations, or their neighbors monitoring their thinking in their head, or the FBI is tracking them. They still believe that, but at least they're able to articulate that to you and say that's what they believe and continue on with a normal conversation. Um, and so antipsychotics have been seen to be highly effective, and I have witnessed that personally. So typically it's given in an oral form and it's also given intramuscularly, and that is a very short acting medication. Sometimes that is necessary for clients that are highly disorganized and present a danger to themselves and others. And there's another thing to keep in mind is that higher dosing does not improve the efficacy, but it will increase the side effects that they're experiencing. And some of these side effects can be like uncontrolled drooling, very lethargic, difficulty concentrating and paying attention, just being very, very tired. So it's kind of like a zombie effect. So, as a social worker, why this is important to you in a hospital setting or in an outpatient setting is because clients will come to you and they will talk about their medication. And I guarantee you, it's not just with antipsychotics, but any medication. It could be high blood pressure medication or high cholesterol medication or anything. If if you have those side effects that are very significant and interfere with, or you perceive it to interfere with your quality of life, then you're not going to take it. And it can lead to non-compliance. So, as a social worker, in a hospital setting, you see that and you absolutely should note that in the emergency record. You should bring it to the attention of the attending physician, and you should bring it to the attention of the attending psychiatrist or whoever the prescriber is, to make those modifications to the medication so that the client can have increased efficacy while also maintaining a quality of life, right? And you should not rely on the CNA or the registered nurse to bring this up in interdisciplinary meetings. This should be something that you report because this is what you saw. And even if the nurse or the CNA did report that, it's important to note that you saw it. So this is not an isolated incident. This is something that we're seeing when we see the client walking around in the hallway, or when we visit them in their room, or when we have a conversation with them. This is something or side effect that persists, therefore requires an adjustment in medication, and for however long that they're experiencing it. If it's in an outpatient setting, then what you really want to do, if you're in a network, like for example, in my internship, we were in a network, so the outpatient and inpatient facilities were connected. So you could communicate this through the electronic health records through secure messaging to the treating physician. However, if that is not the case and you're not attached to a hospital, or you or the person is not seeing the psychiatrist or doctor that's in your facility, then you really want to empower the patient to communicate that to their physician, to their provider, to their psychiatrist, psychologist, whoever, that there needs to be an adjustment in their medication. And this is why, because I'm too tired to get up to go to work in the morning, or I'm too tired to do my homework, or whatever it is that they need to do, because eventually they're just going to stop taking their medication because they don't want to um, go through the day feeling lethargic, which is going to create a loop, right? Then they're going to start experiencing their symptoms. They're going to start having challenges and difficulties. It's going to become unmanageable. And then you're going to see them back in the hospital setting again. So it's very important that you be mindful of that, even though you are not a physician. You are a part of that person's treatment team. You're part of that person's medical soul tribe. So it's very important that you are helping them out. Moving along to some of the common interventions. So with psychotherapy, that falls into the realm of social work. So cognitive behavior theory does inform the therapeutic approach to schizophrenia. The cognitive model suggests that our thoughts, feelings, body affect our behavior, and they're all connected in a loop. That is the foundation of our cognitive framework, which you can see here on the slide, drives how individuals process information, to the point they can actually manifest some of these things into their realities, kind of like confirmation bias. Everybody hates me because I'm the crazy person in the family. No one likes me. So there's no point in me going to Thanksgiving dinner or the family reunion because everybody hates me. So what you want to do is you want to try to change the way in which the individual processes their cognitive assessment, how they view themselves, how they view their self interaction, their level of confidence, their self esteem, and their hope in how they can manage or live with this disease. So CBT is the common, or the preferred, I should say, psychotherapy that is used in combination with drug therapy. Um, the CBT, and with a combination of psychotic medication, is seen to be the most ideal treatment approach for schizophrenia. DBT is a form of CBT, and it contains skills of mindfulness, distress tolerance, interpersonal effectiveness, and emotional regulations. And it can be delivered through skills training group, individual therapy, phone coaching, and the therapist consultation team. I most often facilitated group therapy, and typically I use DBT as a skill for them, because I know for me, I have a disorder where I have constant ringing in my ear, and sometimes it can be distressful. So when you think about the sound in your ear, it only makes it louder, right? And then it becomes very distressing. And so with DBT, you can teach them skills to help them relax, like calm down, do some meditation, listen to some music, and bring them back to a place of homeostasis and try to balance all of these energies out. Um, or teaching them how to manage their relationships, because most schizophrenia are, I'm sorry, most individuals that have a diagnosis of schizophrenia, they are going to have challenges in managing their interpersonal relationships because of their symptoms. They are prone to have um, incorrect beliefs, some paranoia in there, and then they're going to have some episodes of anger and aggression. And even though individuals in their household know that there's a diagnosis here, even though their friends know it's a diagnosis there, it can become very exhausting. So if you have these psychotherapeutic skills on board, it can really help them navigate those relationships, repair them, and maintain them, um, so that they can get the optimal benefit out of those relationships so that they won't isolate themselves off from the public, because that isn't good. You want them to feel a part of the community, a part of the family, and a part of the household. So the next part is the integrative approach. So this presentation is talking about incorporating or integrating spirituality into the treatment of schizophrenia, which is going to require an integrative approach because spirituality is an empirical modality, right? It's not evidence based, such as CBT, DBT, motivational interviewing, and all of those other psychotherapeutic techniques that we commonly use. Those are all evidence based. However, spirituality, spiritual practices, is just something that enhances those. So it's going to require an integrative approach. And it's used when you're by clinicians when you're using multiple interventions because one, you feel like maybe one is too limited and you just would like to incorporate something else to enhance to get the most out of or to improve the outcomes that you get from your treatment plan. And so you really need to be looking at the four major frameworks: the humanistic, the systemic, the psychodynamic, and the cognitive behavioral, to know which and how to apply your treatment. So that brings us to spirituality. So spirituality kind of goes back to culture because a lot of cultures are driven by their spiritual practices, or in a lot of cultures, they're guided by their spirituality, which kind of dictates how they live their life, right? So um, the DSM-5 talks about cultural and socioeconomic factors that must be considered when your client differs in cultural background from your own. Ideas that appear extraordinary or maybe delusional in one culture is completely acceptable in another, which is no different in spirituality, right? So some of the spiritual beliefs that maybe individuals who practice voodoo may sound outrageous to a person who is Christian. It's absolutely outrageous, right? And to the point that other individuals reject other individual spiritual beliefs based on their own, right? So there's a disparity in Jewish beliefs between Christian beliefs. Are we waiting on Jesus to come back, or did Jesus already come back? And did the individuals that saw Jesus, you know what, right? And so I think about Noah, and think about all the people during Noah's time and the people who knew Noah. Did they think that he was schizophrenic? If Noah was to show up today and he was to tell all of us that there's a great flood coming and that he spoke to Jesus and there's a great flood coming and we need to start working on the ark and we need to start gathering materials and things to prepare, would you believe it? Probably not. And remember in that movie 2020, which is not real, because Noah's Ark then made me think about the movie 2020 and how they were building the ark because there was a great flood coming. And but they didn't want to tell everybody about it because they couldn't build a big enough ark for everyone. So that was kind of sad. But anyway, I got off subject. So back to the presentation. So Noah A lot of people didn't believe him and it sounded outrageous, which is why today we are informed enough to be very careful about rejecting other spiritual beliefs. So it kind of requires you to be really mindful of your own and how it interacts with someone else's. And that's going to come up again later in the presentation. So, some of the takeaways I want you to keep in mind as we over the next few slides as we talk about spirituality, and that is spirituality and religion are not the same. So, religion is very exclusive, right? And spirituality is very broad, so it's very inclusive. It kind of brings everybody into one fold. Whereas religion, they're governed by a strict set of rules, edicts, guidelines that kind of dictate and govern how those followers or those certain believers of that particular collective are supposed to live their lives, and how the culture or the spiritual lens in which they view their place in society and their environment around them. So it's very strict, right? Whereas spirituality is not. So that's something to keep in mind. So individuals with schizophrenia have described increased faith and coping skills, and they often use spirituality to manage their symptoms, which is understandable. They rely heavily on prayer. Religious and spiritual practices can be adapted for psychotherapy. It's very adaptive, very flexible. And 85% of individuals diagnosed with schizophrenia have used religious activities as a way of coping. So, a lot of your clients and patients are likely doing this already on their own. And hopefulness and self reliance was increased with enhanced treatment and that accelerated the healing process. And this is not just true of schizophrenia; it is true of any medical disorder or challenge that an individual is facing. This has been proven that spirituality and the activities surrounding the practice of various religions have helped clients improve. So, getting started. So, integrating spirituality isn't unlike any other psychotherapy. The first thing you want to do is build a therapeutic alliance with your client or patient. And so that is very important because you're not going to get very far if you both are not on the same team, you're not collaborating, and you're not in agreement on how you're going to go forward. The second part is, of course, the same as everything else, and that is the assessment piece, the history taking piece. So, a lot of you are already doing psychosocial assessments. And so you're just adding the spirituality aspect in there. And some individuals or some agencies are already doing that. I know in my internship, they asked about individuals' cultural and spiritual beliefs as a part of their assessment. However, with this spiritual history taking, it's going to be a little more in depth. You're going to ask a little more questions to really hone in on the role the spirituality plays in your patient or client's life. And then lastly, you're going to determine some of the goals of treatment. And so in the consultation process involves training, right? So you want to ensure that you are informed on whatever religious or spiritual practices of your client is. And this could include just reading some journal articles, maybe watching some of but the ceremonies on YouTube. A lot of people since COVID actually record their services. Um, Talking to a chaplain, if you're in a hospital setting, talking to the chaplain or some other individual of the same faith, some other spiritual leader of the same faith of your client to just kind of get a good sense of the religious practice of that individual. And then you have the disquisition and questioning phase. So in this, I have the list of questions here that you can ask your client, right? And so Some of the questions or the things that you can include on your assessment is questioning the role of spirituality in a client's life, asking them, do you have spiritual beliefs that help you to cope with stress? What role do your beliefs play? What exactly has helped you in the past to navigate difficult decisions? Where or from whom do you draw a sense of courage or hope? How has your faith aided your family in the past? So, what you're really getting here is how important is this spiritual practices or the religious beliefs of the client is? Because that's going to help you determine whether or not integrating spirituality into your treatment plan would be beneficial to that client. This isn't going to work with someone who is an atheist, someone who doesn't lean into their spirituality, or whose spirituality or religious beliefs does not play a big role in their lives. Then this would not be a good modality to use with them, because then at that point it would be like you're trying to push something on the client. You don't ever want to do that. And then of course you have the evaluation phase, which um, it talks about using evidence-based tools or some sort of evaluation method to monitor and document the progress you're making with your client. So this next slide talks about implementation. So implementation involves following a prescribed treatment plan, but the process with incorporating spirituality, like I said before, is not linear. It's very flexible, it's very adaptable, so you can kind of weave it in and out as it applies. And some of the activities this is not an inclusive list. This is just some things that were listed in the journal article that you could actually look at, right? And pick some of these things off the list: praying, meditating, devotional reading, observance, acknowledgement of ceremonies or rituals, attending services, singing in religious groups, religious mentorship, engaging with peers and providers. One thing that you could have your client do is research. Let's say they are, like, for example, I don't know. Okay, let's say they're Pentecostal, right? So let's say your client is Pentecostal. So, and they really want to get back involved with church again because they remember when they lived or very early on in their childhood or some aspect of their life, it did play a major role in their life, and they report having positive effects. But when they moved, they just kind of fell off. So a great assignment for that person would be, okay, so your homework assignment is to research the church in your area and then narrow those churches down to three of your top, or rank them, 1 through 10, your top three, right? And then I want you to attend three of those services and then journal how you felt, or journal about the message within that service and whether or not it will be ideal for you. So that is an example of something that you can give your client to do. You're empowering them and you're trying to motivate them and affirm them all at the same time, which is, of course, skills contained within motivational interviewing. So, and another thing that I want to say, which I think I lightly said, but I just want to make clear, this is not something that you're doing with your client. Although you can do meditation with your client, this is something that you're assigning them to do. So you can say, hey, when you wake up in the morning, I want you to meditate. And then I want you to say a prayer. Or you can say, have them review or study their religious text and pull out a scripture that empowers them, or a scripture for protection, or a scripture for empowerment and strength, those kind of things. Have them pull that out and say, okay, this is going to be a part of your daily ritual or your routine. You wake up in the morning, and the first thing I want you to do before you get out of bed is to lay flat on your back, look up at the ceiling, and meditate, or close your eyes and meditate for 15 minutes. And then before you open your eyes, or if your eyes are open, then you can close your eyes. I want you to say your prayer or get into whatever position that your faith dictates to pray. If they're just generally spiritual, then they could probably pray laying down in their bed. Um, you can have them participate in certain religious activities and groups that are offered by their church, because a lot of churches have a lot of peer networking things, and that will really help with clients who isolate. And it would also provide them with other external resources in the community that can help them. Um, so yes, those are very good assignments for individuals who are isolating or who are cutting themselves off from the community, society, and their family, kind of help bring them back into the fold. So those are some things that you can use there. So of course, there's some pros and cons, like with all modalities. So some of the pros that we already discussed before are better acceptance of psychotherapy, better adherence to their medication regimen, and the sense of hope in the management of their disease is increased. Some of the negatives is that a lot of people and family systems will seek help from holy places, or the family won't adhere to the treatment plan because of their spiritual beliefs, or they rely solely on spiritual remedies for their treatment due to beliefs that perhaps this is a demonic possession, which you will see in many faith systems where clients believe that, oh, this is just something, they just need to go to a priest, they're under some kind of demonic possession or this or that. And so they will refuse medical interventions, or they won't follow through with medical intervention. And so you really have to be creative there with trying to incorporate spirituality into a plan that the client and family system will accept. Because many of your clients, with the onset being the late teens to early 30s, a lot of these individuals are still living with their parents. So they are technically adults. Some of the adults that have had the disease for quite some time, a lot of them will have an appointed legal guardian. However, they are adults, but they're still very codependent on their family. Their family does have a very, very high influence on their decision making, right? Because they don't quite have the life experience to make decisions for themselves. So they will often defer to their mother for guidance or affirmation or approval. And so you really got to get buy-in from not just the client, but the family as well. You can't really exclude the parental figures if the adult, the 18, 19, 20-year old is still very dependent on them. You want them to have self-autonomy, but you also know that the mother or father has a high influence on whether or not this is going to be successful. So you really got to get the family team on board. And sometimes for highly spiritual families, they do tend to rely on old belief system, and sometimes they're not progressive or accepting of medical treatment. So that's when you really got to get in there and figure out how can we incorporate their spiritual beliefs so that we can get the very best outcome for the client. And so this is sometimes can perceive as a negative because it does require, it almost forces you as a clinician to incorporate spirituality into the treatment of this client, because the spiritual belief is going to dictate whether or not they're going to comply with your treatment plan or the treatment plan of the interdisciplinary team. So I think it's beneficial for anyone, regardless of agency, to really pay special attention to spiritual and cultural beliefs in order to enhance their ability to build a therapeutic alliance with their client. So some of the ethical considerations that, of course, we all have to take in consideration, because social workers are bound by the National Association for Social Workers Code of Ethics. And so 1.04 talks about competence. So social workers should only provide services and represent themselves as competent only within the boundaries of your education, your training, your license, your certification, consultation, review, supervised experience, and other relevant professional experience. So you really have to ensure that whatever you're doing and incorporating into your practice, that you're competent in it. And not only that you're competent, but you're confident. So you can have all of these things, the education, training, license, certification, supervised experience, but you really need to be confident in your ability to do this. Um, and then conflicts of interest. So as social workers, we should not take an unfair advantage of our professional relationship to exploit others to further their personal, religious, political, or business interests. So how this kind of plays into the conflict of interest I can see here is when you have two different faces, and when your client face system is very different from your own. And maybe you had never even been exposed to this face system, because this client could be from an aspect of, or from a culture that is not widely known, or you just have a broad understanding of the faith practices of a particular culture. And once you do some digging, you're like, this is not something I can get on board with. I feel like that I am at odds with what my faith dictates that I do, right? So that's when you have a responsibility as a clinician and a professional to bring that to the attention of your client, and then perhaps help make a referral or find someone who can assist them, right? So mental health clinicians must be aware of and sensitive to the importance and the role of spirituality and religion in each client's life. It is not something you should dismiss. So a lot of we do our biopsychosocial, and then we skip over religion and faith and spirituality, and that is a part of a human being. Our beliefs in our higher selves, or in a higher being, or something that governs how we all live, it varies from person to person. Most of us have some sort of belief system. Atheists believe in their own self. They believe in their higher selves and their own ability to navigate, but that's still their belief system. A lot of people think atheists are out of their minds, right? And I remember, like, when I was in the military, they used to say there are no atheists in the foxhole. When you're under fire, you become a believer, right? Um, However, you can't dismiss it. They have every right to be an atheist if that's what they want to do. The founding of our country was based on religious freedoms. Therefore, within our society, there are many different faith systems. So it's very important that we incorporate that into our assessments, and that we not dismiss their beliefs and not see how that plays a role in their lives, not just when that aspect is the cause of some of the diagnosis that they're having. Have a self-awareness and actively work to minimize biases and misconceptions that may lead to harm to the client. So have self-awareness. So your client is not delusional if they believe that Christ has not come, or Jesus Christ has not come back yet. They're not delusional, okay? That is not going to be sufficient, to dismiss them. They can believe that. Just because you believe he came back doesn't mean that they can't believe that he did not. So it's very important for you to be self-aware and govern how you respond to people. It's not an opportunity for religious debate, right? Be cautious not to inadvertently alter or reject a client's values and beliefs. Okay, so I skipped ahead a little bit. And then psychotherapists must develop needed competence prior to attempting to integrate spirituality or religion into a client's treatment, which we talked about earlier, making sure that you do some of your research and some training in that area prior to implementing it, only if you're not experiencing that area. If you already are, then that won't be necessary. There are many Christian or faith-based therapy practices that specialize in that. So they do use other evidence-based modalities, but they are experienced in incorporating religion and spirituality as a part of their practice. So, and so then the very next point of discussion that you guys can discuss in the chat box or leave questions or comments. Many clients find their spiritual practices to be a source of strength in challenging times. Has anyone used aspects of spirituality in practice with this population or other diagnoses outside of DBT? If so, was it helpful? So, for those of you out there who have used spirituality in practice, was it helpful? And then this is a reminder to all of you who use DBT that is technically a spiritual practice because DBT was founded on principles that are contained within Zen. So we can all keep that in mind. And it is evidence that spirituality can be successfully incorporated into treatment. So that is a point of discussion for you there. For those of you who are viewing this through um, YouTube. And then, of course, if you have any questions or any comments that you would like to send me directly, this is a box that I do monitor and is at Chanel_Underwood1 at alumni.baylor.edu. And with that being said, I want to thank you so much for attending or viewing my presentation on YouTube and closing out my time here at Baylor University winter class of 2022. Thank you so much. Take care, you guys, and God bless.